and welcome back. This is the second lecture on harnessing large language models in healthcare informatics. So we left off just having learned a little bit about what large language models are, how we do some vector spaces where it's all just math, and why some of the people who are claiming that is AGI are probably a little wrong. Let's start talking about some healthcare specific examples. So I wanted to just think through what are some specific use cases that we can tackle with large language models in healthcare. Well, we can summarize patient history. A large language model can take 40 years of patient history with a 2 million token context window. Most patient charts would fit within that. And it would be able to quickly condense and pull out pieces and parts of that chart. The biggest problem with that is the larger the chart, the less likely we have trained the model to be able to do it well. So large language models only are as good as they are trained, and so summarization is going to work really well for most patients and really poorly for other patients who don't match that generic training that we have done. So generating discharge instructions is another example. Now that one's an example where we're not going to see the rapid changes, the rapid differences that you might see in summarization. Generating a discharge summary is something that we can very much train for because it's going to have very clear examples and very clear opportunities for identifying ways that we can enhance specifics about the patient's situation themselves to make their discharge instructions tailored to them. One of the great things for large language models is it can serve as a translation step. So when you're interacting with patients, it can translate clinical jargon. It can simplify things down so that patients can understand. It can also just give you quick, easy ways to describe something so that it is on the tip of a patient's tongue. It's on the tip of a physician's tongue, but it's concrete examples that might be more intuitive. If I say that you are a bricklayer and I can put things in terms of bricklaying, or a builder, or someone who works with children, and put it into a context that is relevant to you, you are more likely to be able to take the information I'm trying to give you and use it in a meaningful way. Another key area for healthcare is just so much of our data is locked away in audio transcriptions. It's locked away in free text. And large language models have just transformed how hard it is to pull out discrete data elements from text. So if we look at a real world example, ambient clinical notes. This is where we just record everything going on in the patient's room and we apply a model to take that audio, turn it into text. Then we take a large language model that has been given some strong prompting so that it can take that transcription and push it into actual clinical notes. Some of the things to be aware of. There are some pretty stark technology limitations today. Audio to text is not perfect. If you want to think that it's perfect, I encourage you to take 3 pages from your favorite book, read it out loud, and run it through any transcription service that you care to name. You will find that no matter how clearly your dictation, how well that you think that you are going to deliver your speech, the models will make mistakes. there are just inaccuracies that are delivered. Also, with voice to text, it's not going to have the clear delineations that written text will have, with periods and exclamation marks. And so it is frequently a bit challenging, and why it's taken large language models to get to the point that we can make realistic clinical notes from these voice to text models. But note, there's often a need for manual corrections, manual review. Those research studies that have been run on these have found that there are errors that need to be corrected. The question becomes, if we are delivering these on a platter to a clinician and there is one mistake in every note, are they going to try and find that one mistake each time? What if there are 5 mistakes? What if there are one mistake every 100 notes? All of these are decision points that we still haven't made as a clinical community. Some of the things that I'd like you to think about from a large language model perspective, which is taking that voice to text and then converting it, is there's a lack of standardization in the prompt engineering that's going on. Even when people are testing multiple different systems, they aren't leveraging the exact same prompt in all of those systems. That means that you're not actually testing the capability of the different systems, you're testing the ability of the prompt. And there's just a very frequent variability in the data input by vendor over which voice to text they're using. OpenAI released the Whisper models a few years ago, and then a lot of other people have taken and run with those, which do a fantastic job. And uh, really, prior to that, finding an open source voice to text was very challenging. These days, we have many, many. And of course, there's Dragon, which has been the main vendor for years. So this is for the in-person. We're going to talk about what surprises you about LLMs. It'll give me a bit of an opportunity to understand where people are concerned. Then we're going to go into practical limitations. So with large language models, they have a concept of hallucinations. They will just make things up. They will make things up because they're not actually thinking. Um, they are just predicting that next word. So those hallucinations are always plausible, but they are often incorrect. And there are some major challenges in crafting good fact checking. And we solve this often with agent-based systems. Agent-based systems are where you take an LLM and you give it a role and you have it output in that role. You feed that output into another LLM where you have given it a different role, and it reviews that output and makes a brand new output, and it can act as agents, as different people, if you will, uh, working forward in a process. So LLMs also have problems of the more, so we talked about those context windows and the 2 million contexts versus the 128K for the Llama models, which are the best open source models by Meta. DeepSeek is now open sourced, which is equivalent. DeepSeek is a little different from the Llama models, and so what it's achieving and how it's achieving it, it's hard to compare and contrast because depending on your situation, you're going to want different things. DeepSeek uses I think it's 400 and 406, I think, but it's a 400 billion parameter model. But they've carved it out so that it has a lot of specialist modules. And so you are looking at this 400 billion is actually made up of a lot of 32 billion that goes and selects which is the best one for the task at this time. And Llama is taking a different approach where it's all just one consolidated. The Mistral series, also like the 7 series, had 7 of those different attention where different pieces and parts were optimized. Say one was optimized for math, one was optimized for writing. And so we have limitations with how we approach our memory. We have limitations in long-term context because large language models, if I pass it in a million different tokens, it's not going to be able to it's going to be able to answer questions about any of those million tokens. It is not going to be able to leverage all of those million tokens and remain the full context. So when I am telling stories, for example, it will forget that we define someone's hair as red, and it will say someone has blonde hair blowing in the wind. These large language models tend to have poor medical knowledge, they, poor specialist medical knowledge. They tend to be very good at what has been published. They tend to be very good at the textbooks, but they are biased towards what you'll find on Reddit, on websites, and so it often struggles to provide nuance. Uh, we have done testing where we have fine tuned, and fine tuned is feeding in new information into a system so that it is more likely to give you the output that you're interested in. And when we fine tune with additional medical training, it gets decent. Uh, but as a next word token generator, it tends to overgeneralize. And so these are just practical hands on limitations of large language models. Just think about your domain expertise is still going to be critical for oversight with large language models. While they can streamline research, they can streamline EHR capabilities, we have to understand that they can't just go out and do. Uh, a year and a half ago, I released multiple papers on agent models where I was able to leverage agents to go out and do early research and out and do research papers. And they don't, they're not very smart, but they have a real potential for accelerating and reducing the manual work that we're going through. So, literature review automation. If we're going to do a literature review automation, we want to think about how we're going to teach it to scan the abstracts, identify and pull down um, the specifics that we're interested in. So an LLM can summarize thousands of abstracts and do it in a very good way. So think about applying this to your decision support. There are new research coming out on the daily about different things that might be impacted by your decision support. Leveraging an LLM to look at each one of those research papers as they come out, summarize it down, and then so they scan the abstracts, pull all the information that's relevant, put down into summarization, and then leverage that summarization to identify whether or not you need to change existing decision support rules. is something that we can automate and people have automated, but it risks being able to provide nuance. And so when we are contemplating the overwhelming nature of modern research and the amount of publications that come out the door, this is going to give us an ability to operationalize more meaningfully. So we're going to skip this and go. One of the things that I did just want to mention is how much we need into interdisciplinary work. We need teams who are working with large language models that are representing a number of different areas. Just like when we do a research study, we need people with different expertise. So you might be bringing in an IT professional who knows how to do prompt engineering and knows how to do it very well. But you're still going to need to bring health informaticians to the table who might be able to speak to, here's how this process works, here's how we store this data, here's how we think about this data. Obviously, you'll need clinicians to speak to, here's the real world. Health informaticians might interpret that into that real world has now become what we're doing. It goes to the IT professional who gets some prompt engineering, and then the data scientists are going to need to analyze it. We're not going to just be able to turn over every piece of our analysis over to large language models. Even if people like me want to play and test being able to do that, we are not eliminating the expertise that is required. I want to just quickly start teasing our next discussion, and this is the ethical lens of introducing large language models to healthcare. So I try to do this little Venn diagram. We've got bias mitigation, oversight, governance committees. Uh, we need governance committees to look at what we're putting into large language models and how we're doing them. There are going to be situations, and we're going to talk a lot about this in bias, where you shouldn't be using large language models because they are prone to bias. The data that they output is going to have bias. In general, the data that they output is going to try and make it as generic as possible. When I go and use Chat GPT o1 Pro, which is their best long-term thinking model, and I try to have it generate a story. Um, so I wrote a book a year and a half ago, um, which was science fiction, and the protagonist, I did not describe the protagonist. I did not do anything to indicate whether the protagonist was male, female, or anything else. And I did this on purpose. Getting a large language model to be able to generate sentences without using he, she, they is, it's just very poor at the job. It's because the data that it has been trained on is biased to always having gender pronouns. It's biased towards um, the examples that it sees. And so when we're using those systems, because we have trained them, it will tend to go to the most generic, even when we give it in specific instructions, and we can give incredibly detailed instructions. It will be wanting, for lack of a better word, it will be biased towards giving you that more generic content that it expects it to see. Most people are going to have situations where uh, you're going to go back to my story. I used the first name Casey, which can be boy or girl, and depending on what chapter and what action was taking place. During the really high action scenes, it was using male pronouns, and the female pronouns came out during some of the more emotive scenes. And you would think, because it was all in the same prompt, all in the same conversation, it was getting all of that previous context. And that still didn't fix it. So when we're dealing with patients, we need to think about our informed consent. We need to give them information that they need to have, which is if we are generating notes for them and no humans interacting with it, we need to tell them. I don't agree that we need to tell them if a note is generated and a physician is signing off that this is the note that they want to send. To me, that is just a tooling being used, not a lack of informed consent. But as we move forward, as we evolve in our industry, we're going to need to build out more oversight and more specific thought processes on how we can leverage these tools in an ethical, useful manner. So the next video I will give will be on prompt engineering. I hope you come back for it.